Good evening, everyone. It's great to be here with you tonight. Welcome to Catapult Education. And I'm looking forward to spending the next couple hours with everyone. To begin, I'd just kind of like to give you a little idea about what we're doing and what we're going to be talking about. I like to think of this as kind of an informal discussion, about the topics. The MAC dentistry is the materials, adhesives, and cements. Most of the materials we're going to be talking about tonight are indirect restorative materials. I don't, the scope of this lecture doesn't really cover direct materials like composites, but at the end, I'm happy to, try to answer some questions about that if you have them. Adhesives is a category I think is really important, and we're going to spend a lot of time talking about bonding and how we adhesively bond, and then certainly cements are changing all the time. So these are things that are really important if we're doing adhesive dentistry and the type of dentistry that's available to us today. I am really, I want to be sure I kind of tell you right from the front, I kind of like to think of this as a sharing of knowledge or a sharing of information. I don't consider myself any kind of a guru or an expert or anything like that. I've learned most of what I'll be telling you tonight. I've learned from very smart people. I've been very fortunate in my career to have some wonderful mentors in dentistry, some very smart people that I've learned from, that have taught me, that have helped me. A lot of my colleagues in Catapult have been great sounding boards, people that, when we're together, we can talk about things. So I'm going to be sharing this information. Also, if you have a chance, before we go into the first slide, the tew.com is my website, and under that is my email address. If you want to jot those down, one on my website, we have all the handouts for all of my lectures, and you're welcome to those if you would like. Certainly the program we're giving tonight, there's handouts there, there's information, there's a lot of words going to be tonight, and it'd be almost impossible, even if you do really good shorthand, to try to write everything down. So you can jot some notes, jot questions. If you have a question, go ahead and jot it down. So at the end, you won't forget it as it goes on. You can write that down, and we'll be happy to answer questions like Lisa said at the end. And also my email address is there. If somebody doesn't get a question answered, or if they thought of something later and said, oh, I wondered about this, you feel free to email me and be happy to try to answer questions for you. So why don't we go ahead and get started here. So as I mentioned, or as Lisa mentioned too, this is sponsored by Catapult, or who sponsors programs like this, webinars like this, because Catapult is very interested. It's a speakers bureau and provides education to dentists all over the country. And we are, we consider it a really, CE as a very important aspect of what we do in dentistry. In addition to speaking and education, Catapult we also evaluate products, and a lot of these products I'll be talking about tonight. I do have no conflicts of interest. The companies I talk about are products that I use in my office. I pay for those products. I use products because I like them and because I know they work, and a lot of times because I've been fortunate and had the opportunity to evaluate these products and work with the companies. The sponsors, as Lisa mentioned tonight, are GC, Kettenbaugh, Shofu, and Weave. Just to mention a couple things about these people, these are great companies. There are so many great manufacturers, so many great companies in dentistry. We're fortunate as dentists to have these companies that are out there that are working hard. Yes, they're interested in turning a profit like everybody else, but their research and development departments work really hard to really come up with some great products for us that make dentistry better for everyone, for us and for our patients. These are some companies that I work with that I think have some wonderful products that are sponsors tonight. To begin with, GC, for those of you that use resin modified glass ionomers, this is one of the newest ones. We had a chance to look at this product. This is the Fujisim Evolve is a resin modified glass ionomer. The interesting thing about this is they took their Fujisim 2, which is a really good resin modified glass ionomer, and they changed it just a little bit to have what we call the gel state cure. And I'm going to talk about that when we get into adhesive, we get into cements, how these cements you can do what I call a flash cure, and you can cure it into a gel state. And so you can quickly clean it. It's very easy to clean in a gel state. So we'll talk about that, the two ways to clean these cements, when we get into the second half of the lecture. So it's a really good product. It's a resin modified glass ionomer, as I said, that allows that gel state cure. The Genio Bulk Injectables, a new product that came out a little over a year ago that I fell in love with because it's a bulk, but it's also a flowable. So it's something that you can use as a total restorative. I like it sometimes for core buildups because of bulk fill. I can put more material in there instead of doing incremental bulk buildups. So it's been a really fun product for me. I really liked, and my hygienists just love MI Paste Plus. It releases fluoride, phosphate, and calcium ions, and really good for remineralization for people that are in danger of tooth wear, either from acid erosion, from enamel loss, from grinding, things like that. And MI Paste Plus is great for decreasing sensitivity and, like I said, remineralizing teeth. Some really good products there. Kettenbaugh, I absolutely love their impressions. If you're taking 100% of your impressions, you're scanning, then impression materials probably don't matter to you anymore. If you're like me and you still take regular impressions, whether they be a full tray or triple trays or however you take them, I've loved Panasil for a while, and it's so easy. It takes such accurate impressions. Was one of my favorites. I said, you really can't do any better, And so then they asked Catapult to involve. Kettenbaugh came out with a new product a little over a year ago, and they asked Catapult if we would review this product. It's called Identium. And this is an interesting product because it took the polyvinyl siloxane, like Panasil, a vinyl siloxane, and combined it with a polyether, which I'd used polyethers before and really liked because of the accuracy of the impression. So it's really a vinyl siloxane ether impression material. Well, it got really high marks from Catapult evaluation, and rightfully so. It's a great impression material. My remakes now are practically zero using these two products, and really good. And it's so hydrophilic that you don't have to dry. I don't have to worry about moisture or crevicular fluid or anything like that. It still gets extremely accurate impressions. Great products. And this new product just came out last year. Catapult also did an evaluation on this product called SimCore. It's a very interesting product. I'll talk a little bit about this right at the end. It's neat because you basically get two products for the price of one. That's why the Sim is for the cement. It's a dual cure resin cement with their own proprietary adhesives that come with the kit for treating the tooth and the restoration, which we'll talk a lot about later on. It's also a core buildup material. So you get a core buildup material and you get a dual cure resin cement in one product. And it also got high marks from its Catapult evaluation. Really neat product. Shofu, I've worked with this company for years. I've loved beautiful. I like flowable composites. I learned incremental buildup with regular, stackable composites over 20 years ago, and did that for years, and resisted bulk fills, and became a bigger fan of bulk fill composites and resisted flowable composites. And I was asked by one of the guys at Shofu how I do my class 5s, and he said, why don't you try this in a class 5? And I said, okay, Randy, I'll do that. And I did, and I just fell in love with flowable composites in class 5s, in small class 1s and things like that. And then it expanded out from there. Really nice product. They just came out with, and we also evaluated this product last year. This is an interesting product, and there's a couple other companies now that are coming out with these as well. Their new composite is called Fit SA. The SA is for self-adhesive. This is actually a composite resin that's self-adhesive, meaning you don't have to treat the tooth. You don't have to etch. You don't have to use any primers. You don't have to use any self-etch primers, anything like that on the tooth. It's recommended for class 5s. It's recommended for small class 1s and class 3s. It's getting some really good reviews. It's an interesting product to look into, and probably the best camera. If you're not lecturing, if you're not having to have the absolute best top of the line, like a Canon or a Nikon type camera, the iSpecial C3, it started out as a C2, now it's a C3. Their latest camera it's a lightweight, compact, easy to use. Our hygienists love it. It's so lightweight, you can operate it with one hand, so it really makes it nice for hygienists. It has 8 settings. Just a great camera. A great camera if you're looking, takes wonderful pictures. It has a mode that you can do shade matching, works really well for anterior tooth shade matching, something worth really looking into. And the last company that sponsors tonight is Weave. If you're not familiar with Weave, I like to, say that Weave is like for a few $100s a month having an extra employee in your office. It's just really unbelievable. It says here it's an integrated customer communication platform. It does so many things, which I really don't have time to get into, but you can go online, check out Weave. They'll give you a free demonstration. We've been using it in our office for years and I love it. My front desk person, absolutely, I swear, I think she would quit or fire me if we quit using Weave because of how easy it makes her job. The phone rings and doesn't just say who's calling. It has all the patient information right there on her computer screen. It brings everything up for her. It does so many more things as far as patient communication, scheduling. It does, it allows patients to confirm their appointment by text, phone, however they want to, many things. It's really worth looking into. So these are some of the great products that are out there. Some of the companies that are helping this program be available tonight, that might be worth looking into. So with that, why don't we get into what we're going to be actually talking about tonight? And we'll start with the first thing we're going to talk about are materials. And in materials, there are certain factors that affect our material selection. So we'll be discussing that. We'll also discuss what materials are available. I'm going to try to go through, and now remember, this is a half-day lecture. I've had to scale this back a little bit, and I've had to streamline it a little bit to fit the format, the time allowable tonight. But I still want to touch on some materials because it's confusing what materials are out there. And I'm going to actually go through a list from the weakest to the strongest and kind of let you know, an overview. Now they're coming out new all the time. This is almost, it's like I'm constantly having to update this lecture simply because things change so fast and so rapidly. We'll talk about when do we use these materials, and we'll show a few clinical cases just so you can kind of see what they look like. And then we're going to talk about adhesives and cements in the second half of the lecture. And we'll do we'll talk about the adhesive. The bonding protocols are critical. There's two types of cementation. We'll talk about this. There's what I call conventional. That's where you just you clean the tooth off, you try the crown on, you clean the tooth off, you put the cement in the crown, you put the crown on the tooth, whatever kind of cement you're using. You don't have to do anything to the tooth, anything to the restoration. Adhesive cementation is totally different. You're treating the tooth and you're treating the restoration. And there's different ways you can do that, which we'll discuss. So there's certain protocols that have to be adhered to, and we'll discuss what those protocols are. And we'll go through some steps for that. So, all right, so let's start with the factors that affect material selection. And one of the biggest, and it still is today, especially because materials are becoming more and more aesthetic. And it didn't used to be this way in dentistry, but it is today. And you need to know what your aesthetic goals of your patient are, because if you do a restoration that they're not happy with because of the appearance of it, even though it's a good restoration or it fits well, that could be a problem. But we also need to know what are the functional requirements, how much load is going to be placed on a restorative material, because that can affect the material we're selecting. So really, to simplify things, what it really boils down to is we want something that's aesthetic and strong. We didn't always have that in dentistry, but we have it today. And we're getting more and more materials that kind of satisfy both of these requirements. We also need to know the color of the tooth. And the reason this is important is the more translucent a material, the more aesthetic it will be if the underlying tooth color is good. If the underlying tooth color is dark, or it's a core buildup, a metal post and core, or a titanium implant abutment, or a really dark tooth, or an endo tooth, or something like that, a translucent material will not be able to block that out. So you couldn't really use a translucent material. And you would need to be able to use something that might opaque out those darker colors. So we'll talk about what material we might choose that allows us to do that. Where is the tooth located? There are certain materials that work great in the front of the mouth that wouldn't work so great in the back of the mouth, and vice versa. So we need to know that. That will affect our material selection. Is it a single unit or is it a bridge? There are certain materials that, and granted, bridges are clinically, as we diagnose a treatment plan, more and more implants and implants gain more and more of acceptance. Bridges may be not as popular or as widely used as they were, but in my mind, there's always fixed bridge work. There's always going to be need for that in dentistry for a lot of reasons. And we encounter them on a daily basis. Bone, the amount of bone available, whether the patient can afford the implant, whether there was a bridge already there, whether the teeth on either side of the space are going to require restorations there. And it's faster, simpler, easier for the patient, whether the patient's age or medical condition allow them to have implants. There are a lot of reasons why a patient may or may not have to have an implant or want to have an implant. So bridges there are certain materials, if you're doing bridges, and we'll briefly discuss what some of those materials are that we could use, what material we could use as a single unit, but might not be acceptable to do as a bridge. And a biggie is always, and we'll talk about this at the end, we're talking about cementing versus bonding. And when I asked Dennis, if I'm in a room and I ask for a show of hands, who would rather cement than bond? Who would rather cement than bond? And everybody's hand goes up. If their hand doesn't go up, I'd rather cement than bond. It's usually because they're not paying attention and they're asleep, because nobody wants to bond if cementing gives you good results, because it's easier, it's faster, it's easier. We all want to, but there's certain times that we need to bond, and we'll later on this evening we'll talk about what those times are. But if you can take a material that can be cemented and you're going to get the same result as you could get with a bonded material, then sure, cementing might be a really good choice. And our previous experience is important too. If you're getting good results and you're happy and your patients are happy and you're getting good success, I'm not telling you to change. I'm not saying just because a new material's out or somebody says, oh, this material's great, that you need to necessarily change to that material. So previous experience is important. So this is a quote that I saw over 20 years ago. And there's not many things in material lectures that I can still have a slide from 20 years ago because things are changing so fast. But this is from Frank Spear, and it's so to the point. It's just common sense, but it made so much sense to me. He said, all teeth should be restored with the most conservative restoration that satisfies the patient's aesthetic and functional goals. Remember, that's the first two things in our what we're looking for in when we're selecting restorative material. So we're looking for the most conservative restoration. So we're looking, here's our little triangle here. We want to satisfy aesthetics and function, but we also want to satisfy conservation of tooth structure. So if we can do a veneer, we're going to do a veneer because we can satisfy aesthetics and function with a minimal preparation. But we're not going to do a full crown if we can satisfy aesthetics and function with a veneer. But if a veneer doesn't satisfy aesthetics because it's a dark tooth, then we might have to look at another option. So these are the things that we have to look at when we're choosing a restorative material, and some things we need to think about. And Frank is absolutely right. The most conservative restoration that satisfies the aesthetic and functional goals of the patient. That's what we're looking for. So if we think for a minute about an ideal restorative material, we're talking about, we want it aesthetic, ability to mimic natural tooth. We want it strong, ability to withstand occlusal forces, the two things we've been talking about. We'd also like it to be biocompatible. We want it to be color stable, kind opposing dentition, not easily abraded, low solubility in the presence of oral fluids, ease of fabrication, predictability of results, and a versatile product. Versatile meaning it can be used for different types of restorations. So that's a lot to ask from restorative material. And we didn't used to have, when I graduated from dental school, we didn't have anything that was really close to this. We didn't have a lot of restorative options. Today we have many, and we have some that are getting closer and closer, but we still don't have one material. There's not one material that I know of that I have in my arsenal that I think that can satisfy every one of these things, or that I can use in every clinical situation. But I am down to about 3 materials now, and I'll tell you what those are as we go along. And none of them may be perfect, but some of them are actually coming pretty close to what I would consider an ideal restorative material. So we'll kind of discuss those as we go through this first part. So our material options can be divided into 2 categories. They're either monolithic, that's uniform in structure throughout, or they're layered, a layered restoration. Dentistry has really, used to be layered restorations were our main, because we did PFMs. That was our restoration of choice. That was our bread and butter restoration. Porcelain fused to metal, a layered restoration. Monolithic restorations, we really didn't have the ability to bond, and we didn't have the strength of, say, zirconia. So our monolithic restorations were full gold crowns or a gold inlay or onlay. That was our monolithic restorations. We had porcelain jacket crowns, but they had a high failure rate and they couldn't be used in the back of the mouth. So really, we didn't have a lot of Now, today, it's just going to complete 180. Now we see the vast majority of restorations being done are monolithic, and fewer layered restorations. I still rarely do I do layered restorations, but there are some times, which I'll show you in just a minute. There are some situations that are becoming more and more rare, where I still do a layered restoration. So if we talk about monolithic, here's a veneer, and you can see it's very thin, and here's a crown. These are both monolithic, okay? And you can see this is much thicker. A veneer is much thinner. This is more conservative. If I have a good tooth color, I'd always want to do a veneer over a crown, because one is so much more conservative than the other. And this is our, sorry, this is our typical, what we see now, the type of crowns we're doing in the back of the mouth, either a lithium disilicate, something like Emax, or we're seeing zirconia, is a monolithic posterior restoration. I haven't done a layered restoration posteriorly, and I can remember when. It's been several years, because the reason these restorations are strong, they're durable, they hold up. Zirconia is a very strong material. It looks good in the mouth. It's easy to fabricate, meaning it's less expensive. So there's a lot of reasons why these materials are so valuable, and I'll mention more of that as we go along here. So this is a layered core restoration. So this is a layered zirconia. This is actually a zirconia core right there. You can see the brighter, more opaque white right there that you see. And then you see the layering ceramic. So you see that you've got the bi-layering here. You got the core material and the veneering ceramic over it. The thickness is about the same as the all porcelain crown there. Now you'd say, well, why would you want to go to the trouble to have a core and have a layering ceramic? And the reason is when you encounter a clinical situation like this. So you have a really dark tooth. This is an endodontically treated tooth that never got a restoration. It leaked, it got dark. And when the patient finally came in, the patient had an extremely dark tooth, and there was but he also had acid erosion on the anterior teeth. So he was going to need some type of veneer restoration on the other maxillary teeth to restore the worn lingual incisors. But if we put a veneer over this tooth right here with an aesthetic material, you would have show through. So I can't, even a thicker crown of a translucent material that we want to use on these other restorations. So what we decided to do was do a layered core crown over the endo tooth, and then just do regular lithium disilicate restorations at a very translucent shade on the other teeth, because the tooth color was really nice. So the opaqueness of the core can block out the color, but then the layering ceramic can blend in with the other teeth. But if you just if you try to do an opaque crown, say like you said, well, I'm going to use a more opaque ingot for a lithium silicate like an Emax crown, or I'm going to use a zirconia crown there because it's more opaque, then you're going to have a tooth that's going to be less attractive, and it's not going to blend in with the more aesthetic restorations on the other teeth. Or if it's a natural tooth you're trying to match it to. So here's the final result. So number 8 right here is a layered zirconia crown, and the rest of these are just Emax restorations. So you can see we got a fairly nice blend and a fairly nice shade, and we're able to block out the darkness of that tooth number 8. That's where I find layered zirconia can be a real help just in certain clinical situations. But those are rare, and we don't see them that often. And say another place where I'm using layered zirconia, mostly in anterior now, because I want the block out, or I need strength. If we have a long span, I don't like 3-unit bridges, anything longer than a 3-unit bridge out of a lithium disilicate, a more aesthetic glass restoration. Even if I use translucent zirconia, I wouldn't want to go more than a single ponic. But if you've got a long span bridge, maybe double abutted or 1 or 2 ponics or something like that, I want the strength of the zirconia core. But I want to layer it with a ceramic that's going to be really aesthetic, and which would be more aesthetic than a solid zirconia or a traditional zirconia, the stronger zirconia. So that's why, that's another clinical situation. But mostly all my layered restorations now are porcelain fused to zirconia, and they're in an anterior type restoration. So let's go through the materials real quick. I'm going to go from the weakest materials to the strongest, kind of in order. And we're going to jump around just a little bit because some came out before others. They didn't necessarily chronologically occur in the order of strength, but we're going to list them in the order of strength. So we go from the weakest to the strongest. So the weakest materials would be what we call our feldspathic porcelains, or our powder liquid ceramics. You can see they're not very strong, 60 to 100 megapascals of strength, the weaker materials. But I have a lot of patients that had feldspathic veneers that were done 25 years ago. They're still in the mouth and they still look good. So they will hold up on anterior teeth when bonded to the tooth. The big drawback on feldspathic is it's labor intensive. It takes a really talented ceramist to make these look good, and they're time consuming and they're difficult to do. And they have to be fired, continuously fired and layered and built up. And so they're pretty expensive. And sometimes it's just not cost effective, because the aesthetics we can get with, say, pressed ceramics and milled ceramics can come pretty close to the aesthetics of these, and they're stronger and they cost a lot less. So that's, would I use them today? Absolutely. It's just that I would, to get them done really well by a world-class ceramist, it would cost more than I'm willing to pay. The next big jump came though with when Ivoclar came out with Empress. Empress, was developed to use the lost wax technique. It was a molten ingot of ceramic material. It's a lucite glass, and it had really excellent fits. It kind of revolutionized industry for a while, because now you didn't have to have the technical ability to make outstanding restorations. Authentic, most people don't know, was just as really good restorative material. It's also a lucite glass, but Empress had already come out and really had captured most of the market share there. But I still use this because I think there's certain patients that Empress or this lucite glass ceramics look great in, and they're mainly usually females are usually going to have strawberry blonde, red hair, things like that. Emax, to me, the more translucent shades of Emax or lithium disilicate tend to gray out sometimes a little bit. And so I still like Empress today, and I still use it because of the technique. The fabrication technique is not as labor intensive as feldspathic porcelains. It can be done at a more reasonable type of price, and you can have some beautiful restorations with it. There could be some people in the audience tonight that do some chairside milling. And if so, I added this category right here because you might know about it and you might already use them. They're called the resin nano ceramics. GC has Cerasmart and Shofu has Ceramaz. These are both really good products. They don't have to be fired. They're not real strong. They're about 200 megapascals. They're resin based, so they could be polished. They could be repaired. They could be repaired in the mouth. They hold up pretty well too, and they're really simple. They're very easy to mill, and since they don't have to be fired, you don't have to have an oven to do these restorations. So it's something to think about. They also, believe it or not, can make some pretty nice long-term temporaries. If you assume the cost, or the patient assumes the cost, you might be able to make something that looks really nice in the mouth and will hold up for a long time. So just a little category there. But the next big breakthrough, in my mind, one of the major breakthroughs that we've seen in dentistry was the milled and pressed lithium disilicate. And today we see, so Ivoclar came out with an Emax CAD, which is the milled, and the Emax press, which are the ingots that were done just like Empress. This was twice as strong, or 3 times as strong. The CAD was 360 megapascals. The milled was 400 megapascals. So what we saw was a much stronger material that could be used for posterior crowns with a great deal of success. The other thing that was great about this material is that it was very aesthetic too. It had very good translucency and optical properties that allowed it to not only be strong, but to be very aesthetic. And then it could be cut back and layered, just like Empress was cut back and layered to even increase aesthetics. Ivoclar had a patent on this product. The patent ran out a few years ago, and now you're seeing a lot of companies come out with their lithium disilicates or lithium silicates. One of the ones I love that's a beautiful, has beautiful ingots is the Lisi press by GC, the initial Lisi press. It's a really, really pretty lithium disilicate. But again, Emax CAD's been out for a long time, but because they were the only one doing lithium disilicate, you really had good, I felt like you had good quality control. I think Ivoclar was able to really ensure good quality control with this product because they were the only one making it for a while. But we'll talk a little bit more about lithium disilicate and why I like it. Then his strength, as far as strength goes, it wasn't the next one out chronologically, but I think this evolved the translucent zirconias. The translucent zirconias, crystalline ceramics. Zirconia is a solid crystalline. It has no resin base. It has no glass base. Okay, it's a solid crystalline. Okay, and that means that it can't be etched and it can't be salinated like glass ceramics or like these nano ceramics. So you have to treat these with a primer, and we'll talk a lot about how we bond zirconia in the second half of this lecture. But crystalline ceramics first came out as the traditional zirconia, which is stronger. You'll hear some terms today, and they'll talk about Y, 3Y, 4Y, 5Y. Y is for yttria. Yttria is used to stabilize zirconia. So as yttria, what they found out, what the manufacturers found out, is that yttria, when added to, or sometimes you'll hear also in terms of mole, MOLs, 3 mole, 4 mole, 5 mole. So 3 mole or 3Y is traditional zirconia, which is the next category. I'm going to go ahead and do this, and then I'll go back, talk about both. So our high strength crystalline ceramic zirconia, the first ones out were the 900 to 1200 megapascals. And some people will tell you there are highs, maybe as high as 1500, very, very strong. Once you get around 1000 to 1200, you really don't need to be any stronger than that. But these were the first crystalline ceramics. The problem was they weren't as aesthetic as lithium disilicate. They were good. They were better than metal, and they were very strong. You could use them anywhere in the mouth. So what the manufacturers discovered, if you added yttria, which is used to stabilize, if you added it, it became more translucent. So 3Y became 4Y or 4 mole, and that became more translucent. And then 5Y or 5 mole became even more translucent. So Katana, which I think makes a beautiful translucent zirconia, they have the multi-layered blocks now. So these blocks are shaded and to simulate gingival, body, and incisal characteristics. So they come out milled, ready to go. And then they had so you had the multi-layers, the super translucent multi-layers, and then you had the ultra translucent. So this would be the 5Y right here, the very, very translucent. These really mimic anything that lithium silicate could do as far as aesthetics and translucency. We get into bonding. I'll talk a little bit more about this. Do I like these? Can you create the aesthetics with this? Absolutely. There's some beautiful, you could do with some beautiful ceramic work with this new translucent zirconia. It's pretty amazing. But the strength of zirconia is in its ability to withstand crack propagation, okay? So that's what makes it so strong. Zirconia, the traditional zirconia would undergo transformation toughening. So it has a very high flexural strength, but it also can withstand crack propagation, okay? Now, as you add yttria, it decreases the flexural strength. So these are not only are they not as strong in megapascals, but they also don't have the ability to withstand crack propagation as well either. So they are more translucent, but they really you don't have the strength that you have with solid. That's why if I'm doing posterior restorations, I'm going with traditional 3Y zirconia. If I'm doing anterior restorations and I'm looking for more aesthetics, these new translucent ceramics are absolutely beautiful. And you could do some wonderful things with that, especially if it's a full crown and you're gonna bond this on, and you don't need the higher bond strengths you would with, say, like a veneer. And that's my biggest thing. I think you can bond glass ceramics and get higher bond strengths, even though we can bond zirconia. And later on, I'll tell you how you bond zirconia. I don't think you get the strength with zirconia bonding that you do with the glass ceramics. And we'll talk about that as we go on. So that's kind of it in a nutshell right there. There are a lot of other great products in here that would fit into these categories, but this is a little bit of an overview to give you some idea of what we have available, to use as restorative materials today. So why do I like lithium silicate so much? Well, one thing, we said it's strong. It can be used as single unit posterior crowns with high success. You do need a minimum thickness, so this is where it differs from zirconia. With zirconia, I'll go as thin as a millimeter. I would not want to do lithium disilicate a millimeter. I want 1.5 to 2 millimeters of occlusal clearance for lithium disilicate in a posterior restoration. But it is strong enough for crowns if you have a minimal thickness of at least 1.5 millimeters. It can be milled or pressed. It gives you some fabrication advantages there. It's very versatile. It can be used for veneers or thin veneers, very thin. It can be pressed at 0.3 of a millimeter, which is very thin, which allows you to have a extremely thin veneer and a very aesthetic veneer. It can be used for crowns, anterior 3-inch bridges, inlays, onlays, implant abutments, and restorations. So a very versatile product. This is an idea about what they look like, how thin these veneers could be. Very thin with lithium silicate. Very easy to fabricate, whether you're milling them or pressing them. Can be bonded, Or on posterior restorations, if you've got enough thickness, at least 1.5 to 2 millimeters of thickness, they can be cemented. And they're the most aesthetic of the high strength materials, especially when cut back and layered. Now you can say the new 5Y zirconias rival those. I should mention too, this is interesting. I'm going to go back really quick because I forgot to mention this. This is a new product that just came out. Ivoclar launched this product last year, and they seem to think they've really hit on something because I keep talking about 3Y, 4Y, 5Y. Zircad Prime, they have developed a material that actually combines 3Y, 4Y, 5Y all in the same block. So it has the aesthetics of a 5Y and the strength of a 3Y. And you know, they've come up with this, and they've done a lot of research on this, and they've done a lot of development before they launched this product. So it's a pretty interesting product. But again, you can get some really, really pretty zirconias with the more translucents, and they will rival the aesthetics of lithium silicate. So one other thing too about lithium silicate, I mentioned this a minute ago. See, they had 10 years, they had 98% success rate after 10 years on the market, 10 years before anybody else had come out with lithium silicate. So again, that's a track record that translucent zirconium just doesn't have yet. Now, it may equal that, but we won't know for a few years. And we still are not even at 10 years on some of the other zirconias. We just know the strength of zirconia. Zirconia, remember, zirconia has a very high flexural strength and a very high compressive strength. Glass ceramics have a high compressive strength, but they don't have a high flexural strength. So that's where zirconia makes a big, big difference. And the advantage of zirconia, again, is strength, as we talked about, less occlusal clearance. See, I started out, I love these for second molars where I didn't have a lot of room back there because I didn't need the thickness, or I didn't need to prep more tooth. It can be used with feather edge. I usually use a very small chamfer when I do zirconia. What that does is good is it allows you to prepare less tooth. Your preps can be more minimally invasive because you don't need a thicker margin there like you do with some of the other ceramics. It's more aesthetic than metal, even the more traditional early zirconias, especially when they're colored right and stained properly. They can be very aesthetic. They function well under heavy occlusal loads. They can be cemented, or if you don't have good retentive properties, which we'll talk about later on, they can be bonded, and we'll tell you how we do that. Very easy to fabricate and low cost. One thing I'll caution you on is you still want to pay. If you see an advertisement for zirconia crowns, $59, $69, I'd be a little careful about that, because you don't know where these how they're being fabricated and where the blocks and pucks are being made, or sometimes if they're too inexpensive, it may sound good, it may look good, but I would stay with your laboratory that's using, they're getting good quality products, and not just try to see the cheapest one I can get. But still, we can get really good quality restorations at laboratory fees for around $100, $100 to $120, and even a little bit less sometimes. So really one of the big advantages now, I think, are low cost in these materials. Not only do they look good, but low cost. I mentioned this a little bit. I just go through the clinical situations where I use layered core, anterior crowns with tooth colors dark, that endo tooth case that I showed earlier, anterior crowns over metal post and core, anterior crowns over titanium implant abutments. Had a patient came in, already had the abutment placed, and we usually do, to use more translucent materials, zirconia abutment on in the aesthetic zone. Well, the patient already had a titanium abutment in the tooth. So we did a layered core, and you couldn't even tell. It looked really good and matched in with the other teeth. So this possible. And then long span and multi-ponic bridges. These are the cases. So am I using layered? Yes, but not very often. It's usually going to be one of these four clinical situations is about the only place I use layered zirconia anymore. So we'll look at some lithium silicate, we'll look at some zirconia, and then we'll go on into adhesives and cements. So I mentioned versatility. One of the things about lithium silicate, it is a very versatile material. It can be used for a lot of different types of restorations. Now, this was a restoration that was done years ago, and we were going to do, the patient had a 2-unit bridge here, a 3-unit bridge on this side. what had happened, he was continually missing laterals, but the canines had migrated into the lateral position. So he had ponic spaces where the canines should be. And so he'd had a cantilever bridge done on the right side and a 3-unit bridge done on the left side. And so he's got interproximal decay on 3, 4, and 13. And he's got a PFM crown with recurrent decay on 14. So we're going to do 2 3-unit bridges here because the canine was broken down. We're going to do a full crown, and we're going to do 3 onlay veneers on the 2 premolars and a molar here, and then 2 veneers. So actually 4 different types of restoration: a veneer, onlay veneer, bridge, 3-unit bridge, and a full crown. So 4 different types of restorations, and I'll just go through this kind of quick. Here's the after, but here's the looking at occlusally. Here are the 2 veneers. Here are the 2 3-unit bridges. Here are the 3 onlay. You say, why onlay veneers? Well, you know, it's interproximal decay and some restorations there. We want the facial surfaces to match, but we want to preserve the lingual cusp. This is healthy tooth. So now we got our centric stops and a natural tooth, and then our full crown on tooth number 14 right there. So 4 different types of restorations. Now today, I would probably consider doing submitting these in either Emax or zirconia. This is a case where a translucent zirconia would look great in the front of the mouth, and I could go ahead and cement that. I'd rather cement than bond. So if I can get a really aesthetic material, which you can get with translucent zirconia, I might use that here, still do my veneers. I match Emax and zirconia all the time now. And I'd probably go ahead and you know, if I'm doing onlay veneers, I'm going to do Emax here. And I would certainly do a zirconia crown here. I just do a traditional zirconia crown on 14. So this wouldn't be all in Emax anymore. This would be our lithium silicate. This would be a combination for me in 2 different types of zirconia and Emax. So just to show you how dentistry has evolved for me, when we did this, lithium silicate was beautiful because I was able to do everything, and everything matched with one restorative material. But that doesn't mean that we don't change as time goes on. And I've changed big time when it comes to zirconia. I was hesitant when it first came out because I was having so much success with lithium silicate. I didn't really see a need for zirconia until somebody said, well, you know, do you ever have those problems? Remember, we used to do full gold crowns all the time on second molars. For you young dentists, you probably don't even know what a full gold crown is. But for us, we had to learn how to do them. In dental school, I had to learn how to make full gold crowns. We had to fabricate our own. And we had to wax up the patterns, burn them out, just like they do, you know, pressed ceramics now, you know, and then get your molten gold and sling it into the burnt out wax pattern. Now they just do it with molten ceramic. But you can see this occlusal clearance right here. We don't have very much room. So I started doing zirconia crowns, and you can see it's zirconia because it doesn't have that frosty look. And even went so far as doing in cases like this, we're doing 2 crowns, no clearance here. I had enough clearance in the premolar. So I did the premolar in lithium silicate, and the molar in zirconia. So here you see a frosty on the lithium silicate because it's glass and it's etched. And then you hear here's the solid crystalline that isn't etched because it's a solid crystal, it's zirconia. Now it'd be crazy to do 2 different, I just do all this in zirconia. All my posterior restorations in zirconia now because it looks so good. And because I can cement it and it's even stronger. And this is what I do now. This is a combination case now. I used to do this all in lithium silicate. Well, I feel like I need to bond that on. Not now. I do it in zirconia. I'd rather cement zirconia than cement lithium silicate. So I do this case now. I do the anterior in lithium silicate, although I would have no problem doing this all in zirconia today. And I would do these in translucent zirconia and these posterior premolars in traditional zirconia. But this is Emax. The 6 anterior teeth are Emax, and the 4 posterior teeth are zirconia. You can't really even tell a difference. They look that good in the mouth. So, you know, it's just, I'm trying to show you that there's a big evolution now, and I'm trying to tell you how I would do it. This is what I wouldn't do. I did it. Ceramist, he called me up and he said they had a promotional thing going on. If I had a case that I thought where I could do zirconia veneers, they'd like to try them out. Fortunately, the patient loved them. I didn't really love them that much. Fortunately, also, they stay bonded on. So you can bond zirconia. How do I know? Because these are non-retentive preparations. This is non-retentive right here. These are zirconia veneers, okay? And this was before the newer translucent zirconia. You can get some katana now that just blows you away. It's with the right technician, the right ceramist, they could do some spectacular things with translucent zirconia. Spectacular. But these stayed in. That's how I know you can bond zirconia. There's two reasons I know you can bond zirconia. We do wing bridges, which I'll show you in a minute, and our wings are made out of zirconia, and they're non-retentive, and these veneers are non-retentive. So you have to be able to bond for these to stay in. So you can bond zirconia. Do I love the case? No, but they're still in, and they're strong too because they're zirconia, so they're strong. So what about layered zirconia? Well, you already saw that one case with the dark endo tooth. So the two cases where we do layered zirconia are bridges, single crowns on anterior teeth, and these little wing bridges that I just mentioned. Okay, that was a good segue. I didn't realize this was coming up in the lecture again. My lecture is a little different right now. I usually know exactly what the next slide is, but I've had to streamline this a little, take some of the slides out, and I'm gonna have to pick up. So let's see, 7:30. I need to finish at 8:15. Oh, we're doing good on time. Okay, I still have almost an hour. I'm trying to keep up with my time here. So this patient came in. She's young, too young, about 15, 16 years old. Doesn't want to wear a flipper. Mom doesn't want her to wear a flipper, and I don't blame them. But we can't do implants on this patient yet. She's way too young to do implants, but wants something fixed. So we go ahead and make very, very conservative preparations on the lingual of the two abutment teeth, and this is how it looks on the model. And then we bond these wings to the back of the teeth. If you have occlusal clearance, you can even leave a little bit more. It doesn't have to be flush with the tooth unless your occlusal clearance doesn't allow it. So we can even do less preparation if we have a little bit more overjet in the back. But here they are bonded in. Again, very conservative. But these are zirconia, and then the zirconia is layered on the facial with a more translucent aesthetic type ceramic. Okay, so this is layered zirconia for aesthetics on the facial and strength in the wings. And then we have to bond that zirconia in so it stays in the mouth. And here they are after. So again, a nice option that allowed the patient to find, and by the way, we saw this patient was in for hygiene a few months ago, and they're still doing good. They've been in the mouth for probably 8 years now, and they still look good. And this is what I tell the patient, and I tell the parent. I said, we like to get 8 to 10 years out of these. But when the patient gets old enough, you can just section the ponic out, and then you can do implants if you want. But these look like they're going to hold up a lot longer. She might get 20 years out of these. Who knows? And there's the before and after. And then one other case, remember I said long span bridges? Well, we're looking for what could be aesthetic. Well, we could do layered zirconia. Plus we had to deal with this defect right here. So this is a combination of layered zirconia bridge with pink porcelain. Here's the temporary, and this is a pink composite we use to communicate with the laboratory. Here's our provisionals, and we have double abutted on two sides. So we're not going to do this at Emax or translucent zirconia. We're going to do this in layered zirconia with a little pink porcelain. And so they put the pink porcelain up there, and what it does is when the patient smiles, the teeth look the regular size, and it fills a defect in for lip support. So we're able to go ahead and create a more aesthetic result. And we've used these. Sometimes when you see teeth that have a lot of gingival recession, restore them, instead of having one really long white tooth, we've done this several times now. You could do this one of two ways. You can have your they have pink porcelain shade guides and pink composite shade guides. GCE has some great, and Shofu both have great pink composites, And you can do it yourself. You can go ahead and bond composite to porcelain in the mouth, and you can sculpt it and shape it yourself, or you can have the laboratory do it in pink porcelain. Just something to think about there as far as if implants aren't indicated, what are you going to do? Well, there are options there. And what about long-term provisionals? What about a case like this? There's another material we talk about is what do you do when a patient's going to have implants done and they're going to have a provisional in their mouth for a long time? This patient comes in. This is how I saw her. First day we saw her. Failing. Well, here it is. Failing. She's got like a 5 or 6 unit bridge here or something, and 3 of the abutment teeth are failing and non-restorable. So when this bridge is taken off, she's going to have a space of 5-tooth edentulous space. And our treatment plan called for 3 implants and a 5-unit bridge. And this also was going to be with pink porcelain because of the way the case was and because of the gingival recession, after the extractions, implant placement and everything. So here she is pre-op. The teeth are extracted. She sees our periodontist for the implants. Patient comes in. We took the other work off, went ahead and took a quick impression. And sent that to the laboratory, and this is a PMMA, and this is some really great material. This is really, it's heat and pressure treated in the laboratory, so it's stronger than any of our chairside provisional materials, and it's going to hold up in the mouth. It's going to look good for a long time. She wore this for at least 6 months, I think. This is it in the mouth, and it looked good. So just again, a material to think about as far as what are your material selections, what are your material options when you're treating something long term, and you know the patient's going to be in provisionals for several months. PMMA is a great material, and our laboratory does a beautiful job. They even they'll make them two ways. They'll even reinforce. They'll do some fiber reinforcement of these PMMA long span restorations too. So it's pretty neat. Okay, so that brings us to the second half. After materials, now we're going to spend next, I guess, 40 minutes, 45 minutes talking about bonding agents in our cements, and then we'll show use of these materials. And the way I'll tell you, this lecture, when I first started lecturing on materials, it was simply because we were teaching some courses. I was actually involved in teaching some live patient hands-on courses, and there was always big discussions about, okay, what material are we going to use and why? So we actually started incorporating a lecture on materials, because materials, this is 20 years ago, and materials were already starting to change. We were already starting to get some new materials out, and as materials came out, especially when Emax came out, we had feldspathic porcelains, we had the lucite porcelains, and then Emax came out, and then layered zirconia came out. Zirconia first was introduced as a material strictly to be layered. It was not introduced as a monolithic material. I think it came out as a monolithic material because of the success of Emax, because lithium disilicate was used by Ivoclar way before they introduced it as a monolithic material. Ivoclar used lithium disilicate as a layering material for anterior 3-unit bridges, because dentists were having cases that they were doing small design cases, and they were sending it to the lab, and they were doing 3-unit bridges in Empress, because Empress was stronger than feldspathic, and they were failing. And so Ivoclar said, well, we're going to come out with this material, and they had lithium disilicate as a material, and they layered the lithium disilicate for anterior 3-unit bridges, and they called it Empress 2, E2. Well, whenever you layer something, there's a thing called the coefficient of thermal expansion. So the CTEs have to be, it was easy. They had many years to figure it out with metal, but ceramics and zirconia react differently. So layering ceramics, whether it be a glass ceramic like lithium or zirconia, there was a big learning curve there. So E2 wasn't real successful at the beginning, but then they reintroduced it with a new lithium disilicate that they layered in. It was very successful, but the problem is they realized it could be just as good as a monolithic material, and that's why I think that's when Emax got launched, and the two major components of the Emax system were lithium disilicate press and lithium disilicate CAD, the Emax press, the Emax CAD. So that's how, these materials were changing rapidly. So we were talking about these materials, and the questions you would get now when they start to understand materials, this would say, well, how do I put them in? And when do you cement and when do you bond? And that's what they want to know. And I said, you really can't talk about materials if you don't talk about how you adhesively bond them when you need to, or how you cement them, and what cements to use, and what bonding agents to use, and what materials and when. It's kind of funny how here's what dentists really like to know. They want to know what materials do I use, and they want to know how do I do it? Okay. So a lot of times, who's really good at that? They're the people with the full room. Gordon Christensen, one of the best. He knows them all. He knows everything. He knows all the materials. And, they got CRA. They got all the people doing all the studies on them. So they got all the research going on right there at his fingertips. So Gordon is great. I mean, he's the master, but he knows all the whats and he knows all the hows. But there's a lot of other things that are important too. So what I try to tell dentists sometimes, what helped me the most, yes, I would sit in Gordon's lectures, and yes, I sat in a lot of lectures, and yes, I listened to some of the top people like Frank Spear and John Coyce and all these people that are just wonderful lecturers. And I learned a lot of what and how, but what I found out is when I learned the why, that's when I really started to learn, when I understood the why. So yes, what's important, how's important. Those are important. When is important. When do you use certain things? So that's why this lecture is titled that. It's not just the how and the what, but it's also the when and the why. Okay, when do you use them? But most importantly, why? So if we understand why, I think you're going to have a much better understanding of the materials themselves. So bonding agents in cement simply came about because that's the questions I was getting asked. How do we put them in? So remember, materials can be divided into two categories. All materials are either going to be monolithic or they're going to be layered. Well, bonding agents are going to be total etch or they're going to be self-etch. So total etch, or it's sometimes referred to as etch and rinse, it's where you use a phosphoric acid on the tooth. Total etch simply means you etch the entire tooth. I always get a kick out of this total etch because to show you how old I am, when I was in dental school, we were told if etch got on dentin, you would kill the pulp of the tooth. I mean, I know it sounds crazy, but we know now you can etch dentin very successfully and it doesn't kill the pulp if you get etch on the tooth. It won't kill the pulp if you get etch on the pulp. And we were told that you couldn't ever get etch on dentin, and we lived in fear of killing a pulp if we ever got etch on a dentin. So anyway, you can etch enamel and dentin. I want to make this really clear right from the beginning. We'll talk more about this as we go on. When you do a total etch technique, I believe you need to isolate with a rubber dam. I'm adamant about that. I think your high success is going to come whenever you put phosphoric acid on dentin and you open up dentinal tubules, you need those teeth to be isolated. If, on the other hand, you use a self-etch technique and you're not opening up dentinal tubules, you're not putting etch on dentin, I don't think you need to isolate with a rubber dam, and I don't. But I always use a rubber dam with total etch technique, and I don't. So again, if I have to total etch, I will, but if I don't, I won't, because I don't want to have to worry about isolation and all the technique sensitivity and things that could come about. That's why protocols are so important, and we'll get into that. So you can either total etch or you can self-etch. Self-etch came about simply because all the people weren't adhering to protocols. They were skipping steps. They weren't doing it the right people. I mean, dentists. And they were getting problems, post-op sensitivity, debonds, micro leakage, all kinds of problems. And so if you eliminate the phosphoric acid, you eliminate a lot of those problems. So they came about, meaning the manufacturers, came out with products that had acidic primers that could etch and prime at the same time. But they didn't etch like total etch in that they removed the smear layer. They permeated the smear layer, but you could still get really good bond strengths to dentin. So they're successful. Self-etch works. We know that. We can get high bond strengths to dentin with a self-etch technique. So if we're bonding, we're going to be, what are the different etching modes? Okay. So when we're bonding to all or mostly all enamel, if I were in a lecture right now and I had an audience, I would ask for a show of hands or I'd ask for a response. And I would hope most everybody in the audience would say, what technique, what etching mode are we going to use? They would say for all or mostly all enamel would say total etch. Because if I'm bonding to all enamel, mostly all enamel, I want the highest bond strengths and I'm going to get them with a total etch technique. If I said we're going to be bonding to all dentin or mostly all dentin, I would hope my audience would say self-etch, because I want to use a self-etch technique because I don't want to put a rubber dam on. I don't want to open up tubules. If I can get high bond strengths of all or mostly all dentin, why would I want to put phosphoric acid? You don't need to. However, this didn't take care of everything because these work great. But what happens when you have some enamel and some dentin? We've already said we're going to get our highest bond strength enamel with total etch, and we're going to get really good bond strengths to dentin with self-etch. But what happens when you have some of both? And I would hope my audience would say, well, you know, some really smart people, none of them were named Tom Dudney, came up with the idea of selective etch. And when I heard about that, I said, it's brilliant. And this is what allowed self-etch to be so, in my mind, to be so successful. The reason it became successful is simply because you could now use this technique where you would put your etch just on the enamel, and then you would use self-etching primers. So you'd get the etch of the enamel with a selective etch technique. So now this is kind of a hybrid technique of both of these. So generations can get confusing. I don't like anything to be confusing. I don't want to confuse my audience tonight. It's getting late, especially on the East Coast. So I'm going to tell you that I'm just going to simplify things for you. All right. If you want to be a fourth generation guy, some people call this the gold standard. Great. 3 steps: you'd etch and rinse. You'd have a separate bottle for primer. Then you have a separate bottle for adhesive. You could get high bond strengths, very little technique sensitivity when done well, when adhere to protocols, and they worked. The problem for me is it was 2 steps and the adhesives were rather thick. They combined them. The manufacturers got really smart and they said, well, let's just put these two into one bottle, the primer and adhesive in one bottle. We'll etch and rinse. And then they call that the 5th generation, the next generation after the 4th. And so this worked great. I use these for years, putting in veneers. Where do you need your highest bond strength? In a veneer, there is no retention in a porcelain, in a very thin, minimal prep porcelain veneer. There's no retention, but you get great retention when bonded well to enamel. And these work great. And because they combined the primer and adhesive, you had to be really careful. You had to make sure you didn't overdry dentin. You had to thin this out, but it was thinner because they added the primer and the adhesive together. You didn't have thick adhesives. We could light cure it on the tooth and then seat our restoration. It wouldn't interfere with the seat because you didn't have a thick adhesive layer. The 6th generation was to designate total etch from self etch. And the way they came out is you'd etch and prime in one step, and then you'd come with a separate bottle and apply adhesive layer. When you use 2 steps, this system worked, especially after they incorporated the, selective etch technique. 6 generations worked really well. The problem is, even though combining these two worked good from 4th to 5th generation, combining this, it was too soon, before their time. The manufacturers combined the etching and the adhesive primers and the adhesive into one bottle they called 7th generation. Single bottle self etchers did not work. They would work, but they caused a lot of problems. Okay, most of the really smart people out there, okay, Franklin and Tay, John Powers, people like that did a lot of research. What they discovered was that these were very susceptible to hydrolysis and bond degradation. Okay, they were incompatible with dual cure and self cure resins and cements. All right, so you had some real problems with this 7th generation single bottles. So what they came up with is a new generation. The manufacturers now, they came out with, believe it or not, I ask people sometimes, show of hands, who use universal adhesive, and maybe half the hands go up and sometimes less. The 8th generation universal adhesives. So we now use the 6th generation. Make sure if you do, use the selective etch technique, but I don't think you need to, because I think that the best, to me, that we have available in dentistry, and if you get anything out of this tonight and you're not using a universal adhesive, do yourself a favor and look into them. Why? Because you can use either the total, selective, or self-etch techniques with a universal adhesive, and they're single bottles. But because the chemistries have changed, because the research and development allows us now, and the primary reason for this is an interesting thing. Curay had a patent on the MDP. It's an aesthetic phosphate monomer called MDP. It's a big long name, and I'm not even trying to say it. But anyway, MDP, it revolutionized, in my mind, adhesive dentistry and our primers that we see now. Okay, so the 10 MDP monomer is what they didn't have in the original 7 generations that they have now, because the patent Curay had on that monomer ran out, and all the manufacturers started saying, hey, we're going to start incorporating this into our primers. And it made a world of difference. And it's one of the reasons why universal adhesives work so well. And we're seeing the success with them now. They combine etching, priming, and bonding in a single bottle. They can be used with total etch, self-etch, so it doesn't matter. Your product inventory is limited. You don't need to have self-etching primers and total etching primers. You don't need to have 5th generation and 6th generation. You just need one. And it's great because it doesn't matter what you're doing or what technique you're using. Of those 3 techniques, your system gets the same thing out every time. So this would be a self-etch technique, no etch anywhere. This is just etching the dent with self-etching primers. This is selective etch, where we're etching just the enamel margin, and this would be a total etch. Notice there's a rubber dam on there. There's actually a rubber dam everywhere. I don't need a rubber dam here, and probably want a rubber dam there, but here I wouldn't use a rubber dam. Here I definitely use a rubber dam because I'm etching dentin. You can be used for direct and indirect restorations. They have a low film thickness, 10 microns or less, so they won't interfere with the seat of indirect restoration. Now, you really need to read the manufacturer's instructions. This is for Scotch-Bond Universal, Prime Bond Elect, Curefield Universal Bond, Required Dual Cure Activator. There's a lot of them now, but the first one's out. I liked All Bond Universal simply because I didn't need a dual cure activator. Adhes Universal by Ivoclar, you didn't need a dual cure activator, but now there's a whole bunch of them out there. There's at least 10 or 12 of these, and all I ask is that you read the manufacturer's instructions on whether you need a dual cure activator when using it in conjunction with a dual cure or self-cure resin or cement. but they can bond to glass, ceramic, zirconia, precious, non-precious metals, and composite. Now, I will say this, people like Gary Alex, who has written a lot of great articles on this topic, and I agree with Gary. I have a lot of respect for him. And Gary says that he thinks you should use a dedicated primer and you should not use universal adhesives as a silane or a zirconia primer. And I agree with Gary on that. If I'm bonding if I'm bonding a glass ceramic or I'm bonding zirconia, I'm going to use a dedicated primer like silane or like something like Bisco Z Prime Plus for zirconia. We'll talk about that in a minute when we get into how we bond these on. So this is just an example. There's even a few more that have come out since these. The only one on here that's a little bit different is OptiBond XTR. Kerr markets OptiBond XTR as a universal adhesive. It's actually a 6th generation. It's a 2-bottle. It's self-etching primers. They say you don't need to etch enamel. They're the only manufacturer I know that says that, but they have some pretty neat chemistries in their product. But it is a 2-bottle system. But it is marketed as universal adhesive, as is Ultradent's Peak Universal. But the rest of these are all, single bottle or single component. Futurabond is a blister pack. Voco's got a great product, really good bond strength. So these are all good. And I don't care what you use, but I think you would benefit from using a product like this, or at least it's worth looking into. As far as cements go, again, we got 2 categories of materials, 2 categories of etching modes, and we got 2 categories of cements. Cements are going to be either what I call conventional cementation, or they're going to be adhesive resin cementation. Everything's going to fall into one of these 2 categories. I don't care what kind of cement you're using. You can use a resin cement that's conventional cementation. What I mean when I say conventional cementation, it's the way we did it when I was at dental school. That is, you put the cement in the crown, you put the crown on the tooth. That's all you got to do. You don't do anything to the tooth other than clean it off, disinfect it or whatever. And you don't do anything to the restoration. You don't put any cleaner on it. You don't primer it. You don't anything like that. You just put the cement in the restoration, you put the restoration on the tooth. Adhesive resin cementation is totally different. This is where you're treating the restoration and you're treating the tooth. And there's certain specific steps that you have to follow. And we're going to go through those steps. This is done, and to bond, you need a resin cement to bond, to get the highest bond strengths. You can have a resin cement that you conventionally cement with called a self-adhesive resin cement. So that's where it gets a little confusing, but everything is going to either be a conventional or adhesive resin cementation. So do we cement or bond? I asked this earlier, and most everybody's going to say cement, and rightfully so. Why? It's efficient, it's easy to clean up, and it has with some of the newer cements, we now can cement with not only is it fast, simple, easy to use, it's easy to clean up, but it's possibly because of ion release, like calcium and phosphate, things like this. We might even have a regenerative ability where it's the term being thrown out. The buzzword industry now is bioactivity. Do we have some cements that might promote hydroxyapatite formation? Well, there's a lot of research being done, and it looks pretty good, and it looks pretty promising. So if you have a cement that not only adheres to the tooth, adheres to the restoration, is going to really intimately lute your restoration to the tooth, but also might promote healing, promote hydroxyapatite formation, be antimicrobial, preserve marginal integrity, some things like this. It's certainly something that might be worth looking into. Why do we bond? We bond for retention. Obviously, as I said, you have a preparation like a veneer, a minimal prep veneer. It's a non-retentive prep, a wing bridge, a non-retentive prep. You're going to need to bond that. We also bond to strengthen material. When you bond a material, that's why feldspathic porcelains were so successful. That's why I have patients in my practice that had feldspathic veneers done over 25 years ago, and they're still in and they still look good. Because once the material is bonded to the tooth, it becomes much stronger. And we bond for aesthetics. So we want to use a very thin translucent restoration. You can't just use any cement. A lot of times you want a translucent cement or a cement that won't adversely affect the shade of the restoration. So conventional cementation. I hope nobody still uses it. They were successful. Lord knows we used them for many, many years, but zinc phosphate cements can still be around. There's nothing wrong with this. It's just like I tell patients, listen, a lot of people will tell you amalgams are fine, but I just think that we have better materials available. So I think we have better cements available. And I think these are good too. I think both these categories, zinc polycarboxylate and phosphate cement, zinc phosphate, are good cements. and they'll hold a restoration on. I tell my audience a lot of times, I say my mother-in-law has a gold crown, spit in her mouth. She said she had it done. She's 90, she'll be 93 in a couple of weeks. And she said she had it done in her 20s. So what is that, 70 years? You know, I mean, so whatever cement is, and it's still fine. And I'm not about to redo it. So because it looks fine on the x-ray, it looks fine. Marginal integrity seems good. But I promise you, it didn't have a bioactive cement holding it on, or it didn't have, resin modified glass ionomer, and it didn't have a, self-adhesive resin cement, but it's doing fine. So I'm not saying these won't do good. I'm just saying we might have better options available today. Nothing wrong with them. Nothing wrong with glass ionomers. I have colleagues that still love glass ionomers and glass ionomer cements. Very tolerant cements, very moisture tolerant, and big fluoride release. Well, it's great. Kids, elderly patients, great products. But, they lacked in some physical properties like these. So we increased, not supposed to come out the same. Anyway, we mean the manufacturers increase their physical properties by modifying them with a resin. And they call them resin modified glass ionomers. And these are cements. John Burgess at UAB, loves resin modified glass ionomers, and rightfully so. They're a great cement and been around for a long time. This is the Fujisim 2 I was talking about earlier, right at the very beginning. But they've now come out with that tack cure ability with their new Fujisim 2. They call GC calls Evolve. Really good. I love. GC and Shofu both have great glass ionomer products. And I think there's some really big, I think glass ionomers are something that are really beneficial in the field of dentistry. And certainly fluoride release, we all know, we've all seen the effects and the benefits of fluoride release. So this is still a really good cement category. The self-adhesive resin cements are an interesting product because almost every manufacturer has one, and almost all of them end in sim, like Unisim, GSim. The GSim Linkase is just an improvement over GC's GSim, which is a great product. Unisim was 3M product that came out. Unisim, the first Unisim, the original Unisim was the first self-adhesive resin cement. And when I heard about this, I said, you're crazy, because the only resin cements I knew of were like your dual cure, and you had to treat the tooth and had to treat the restoration. And I was being told that here's a resin cement, you just put it in the crown, put the crown on the tooth. You don't have to do anything to the tooth. You don't have to do anything to the restoration. I said, that's crazy. They said, no, there's chemistry in there that actually etches, and you'll get some bond to the tooth and some bond to the restoration. Now, granted, the bond strengths are weak, on the order of maybe 5 to 7 megapascals, but as opposed to maybe 25 or 30 if you're treating the tooth and the restoration. But if you've got a retentive preparation, these will work. And so self-adhesive chemistry has been about, so it's been around. And that's what we're starting to see it being applied now. That's what Shofu is doing with their Fit SA. They're taking this chemistry and this ability to bond a tooth with the chemistries in the composite itself, and they're incorporating that into their restorative they call Fit SA. So conventional cementation, this is the newer category that I was talking about. What some people refer to as the bioactive cements. There's a little bit of controversy about what is bioactive, what isn't. If you want to say there's ion release and ion recharge and that makes it bioactive, fine. If you don't want to say it's bioactive, but if a product releases ions, whether it's fluoride ions but especially, we've had fluoride ion release, but we've known that glass ionomers and resin modified glass ionomers. But now we have phosphate, and we have, not in addition to just fluoride, calcium and phosphate ion release. So we are seeing a lot of benefits from this. I mentioned this earlier about possible, tooth healing, hydroxyapatite formation. There's Stephen Jeffries has done some amazing studies, and one of his studies showed in cementation and crowns with some of these products, you might see gap closure, which could prevent bacterial ingression. So there's a lot of things that are exciting in the future that are on the horizon. One of the first of these was Doxa Dentals. They came out with a Ceramic Crown and Bridge. They recently this was a big, Catapult was really big in evaluating this product. And also we evaluated their new implant cement and really good. This is their products right here. This is what they make. They put a lot of time in research and development in this product, and it's just a conventional cement. It has to be triturated, which to me I think is a drawback because you have to put the capsule in the triturator. But it releases calcium and fluoride. Pulp Dent is on the forefront as far as bioactivity. They have a whole line, their Activa line of products, base liners, cements, and restoratives, their Activa line, but their bioactive cement is a really, really good product. And I absolutely love TheraSym. Bisco came out a few years ago with TheraCal, pulp capping agent for direct indirect pulp caps, which I've used very successfully in my practice. The one thing I'll say about TheraCal is I get asked this a lot of times. It's a learning curve there. If you have used TheraCal and had success because it washes off, it's very important that you don't dry the tooth. You don't dry the dentin. You need to put a very thin layer of TheraCal on the tooth, then light cure it, but you need to leave the dentin moist. It'll adhere to moist dentin. It won't adhere to dry dentin. If it's thin and it's moist dentin, it won't rinse off. But TheraCal is a great product. So they used their TheraCal and they came out with a cement that releases calcium and releases fluoride. And it's in a dual barrel syringe. It's so simple and easy to use. You don't treat the tooth, you don't treat the restoration, and you're going to get some calcium and fluoride release from it too. So I love that product as well. There's some really cool products, and I think we're going to see more and more. You're going to see more and more products coming out. Septidont has a whole line of products of bioactivity. There's some other companies. Parkel just came out with their bioactive core material, and it's a buildup material, a core material that's supposedly does fluoride release and calcium release. So something to look for. And I encourage everybody out there listening tonight to do some research and look into this. Talk to your reps about this and your colleagues at your local meetings and stuff, because I think we're going to see that as time goes on, we're going to see more and more products so-called of these bioactive product categories. So then we talk about, so those are our conventional cements. So what about our adhesive resin cements? So all adhesive resin cements are going to fall into one of two categories, okay? They're going to be light cure cements or they're going to be dual cure cements. Well, I got those back on, I think. So you're going to have dual cure cements and light cure cements. So why do we have light cure resin cements? Well, light cure resin cements were first developed because you didn't need self-cure chemistry if the restoration, like a veneer, was so thin that the light would polymerize through the restoration. No sense to have, because the original dual cure cements, this is important to understand. In the original dual cure cements, the self-cure chemistry had what was called tertiary amines. And these tertiary amines would yellow or darken over time. So if you seeded a translucent restoration like a thin veneer with a self-cure cement, it would work. But the problem is if it darkened or it discolored over time, it could affect the shade of your restoration. So light cure cements, they had no tertiary amines, so we didn't have to worry about that. But the big benefit to me, not only is the color of light cure resins, but they don't set until they're polymerized, unlike self-cure. Unlike dual cure, because of the self-cure chemistry in a dual cure. See, a dual cure cement has both light cure and self-cure ability in there, okay? So it's going to polymerize as soon as the material mixes. And so the chemistry starts. So that's why you have a dual barrel. And it comes down a little spiral, and the two cements, the base and the catalyst mix together, the self-cure chemistry starts. It starts to polymerize. And then you could also cure it with a light because it has light polymerization capability. So for me, in interior aesthetics, so we have new dual cure resins that have eliminated the tertiary amines. So you don't have the discoloring, but what you still have is limited working time. So for me, if I'm seeding multiple restorations, anterior restorations, I wouldn't want to use a dual cure resin because I have limited working time. Unlike a light cure resin. So sometimes if you're doing 6, 8, 10 veneers and you want to put them all in at the same time, which I do, I'm isolated with a rubber dam. If my operatory light is off, I have unlimited working time. So with a light cure resin, I don't have to worry that self-cure chemistry is starting to set up before I've got everything cleaned off or ready to go. And I'm going to show that. I'm going to demonstrate exactly what I'm talking about in just a minute when we wrap up and I show the protocols and show how we actually seat some of these cases. But now if I'm putting a single crown in or 2 crowns in and they're thick and the light's not going to go through there, and I'm afraid I won't be able to polymerize a light cure resin cement because of the thickness or the opacity of, say, a zirconia crown, then I need a dual cure resin cement. I need something I know is going to set even if the light doesn't reach it. But here's an interesting thing. Remember, you can increase the strength of a dual cure resin by light polymerizing too, but you don't want to cure it with the light immediately because then it'll stop the self-cure mechanism. So you need the self-cure chemistry time to work. So I've referred a couple of times when I was talking about, say, Evolve, and when I talked about they have the TAC cure chemistry now. All dual cure and light cure cements have what's called a gel state. Now, dual cure resins, the self-cure chemistry will cure to a gel state, but you've got to constantly watch it, because if it goes from gel state to cured state, it's very hard to clean off, but it's easy to clean off in the gel state. So with a dual cure resin, so let me back up just a second. In a light cure resin, I'm going to show you in a minute, I clean everything off and I tack them down. So I want to hold it in place, and I clean everything off. But with a dual cure resin, it's different because you've got facial margin, lingual margin, you got interproximal margins when you're doing a full crown. So it's easier for me to clean off in a gel state. But what I do is I want to initiate that gel state by shining the light. I polymerize with the light for just 1 to 2 seconds. I go 1001, 1002, boom, my light goes off. What it does is that excess cement that's oozed out when you seat your crown, it will get in a gel state, but you don't want to go too long. If it gets too hard, it's much harder to clean off. Also, if you leave the light on for too long, you might interfere with self-cure chemistry. So I do a quick flash cure, 1 to 2 seconds. I clean it off in the gel state. I floss the contacts. I have them bite on the cotton roll, and I wait 3 to 4 minutes. Why? Because the self-cure chemistry is now setting up, okay? So if it takes me a minute to cure, I like to at least allow, say, 4 minutes. So it takes me a minute to clean off the crown. I let them bite on a cotton roll for another 3 minutes. Then I come back with my light and I polymerize. That's how I do dual cure resins. Light cure resins we do differently because I have unlimited working time. So we'll go through that. Now I'm giving you that. I'm going to show you all of what I just said, but I want that as kind of a lead in here. So dual cure resin cements. I like GSIM's League Force. This is brand new. We looked at this last year. They sent me some of this and asked me to try it. I really like it. This is the new product I told about at the beginning, Ket Boss. It's the 2 products in one. It's a cement and it's a core buildup. It's a dual cure resin cement and it's a core buildup. I also love, there are a lot of good products in this category. And I think dual cure resin cements are important. I think that, like Bisco's Dual Link, Bisco also has a kit that has a light cure and a dual cure in the kit. We'll talk about the kits too. I think I've got that in here as well. So the light cure resin cements, Danville's got a great one, Accolade PV, Bisco's got Choice 2. There's a lot of them out there. Sometimes I get asked, have you ever used a flowable composite? Well, that's what a resin cement, that's a light cure resin cement, is basically a flowable composite. Filler, may be a little bit different, but I've even used a flowable composite sometimes. I like some of the flow, especially if they have a high filler content and they have a pretty good flow capabilities because they stay where I put it. And I know I'm getting a nice color and a little bit of strength with them. So there are a lot of products in this category you can use. And I mentioned that, so in combination cases, you might have a veneer and you might have a crown. You might want a light cure cement for your veneer or veneers, and you might want dual cure for your crown. So some of these, like Ivoclar has the Verlink Aesthetic, the LC for light cure, the DC for dual cure. Bisco has an E-cement kit that has a light cure to dual cure, and Kerr has the Nexus 3rd generation. The NX3 has a single barrel and a dual barrel. So sometimes since you need dual cure cements and you need light cure cements, sometimes it's easier just to have a kit that has both in them. So I just mentioned that. So sometimes it's easy. Product inventory is, as we get more and more materials and more products, our drawers get more and more full, keeping up with all this stuff sometimes. So if you have something that simplifies that for us, that could be a good thing. All right, so let's talk about some clinical applications and kind of wrap this up and take some questions. So we're going to talk about adhesive cementation of glass ceramic veneers. Okay, these are thinner veneers that we can use. It could be like a feldspathic porcelain, a lucite porcelain like Empress, or a lithium disilicate. Okay, so that's a glass ceramic with a total etch technique, meaning we're going to etch the entire tooth with phosphoric acid and a light cure resin cement. So these are veneers that light cure resin cement. Then we're going to talk about if we needed to bond in a lithium disilicate crown with a self-etch technique, meaning we're going to have mostly dentin or, almost all dentin. So we're bonding in our crown. It could be because it's non-retentive, or for some reason we want to strengthen the lithium disilicate or whatever, but we're going to use a self-etch technique and a dual cure resin to show you how we bond in glass ceramics posteriorly with a dual cure resin. And then we're going to show how we would bond in a posterior zirconia crown with a self-etch technique and a dual cure resin. I'd like to stress that I will not bond either one of these posteriorly if I have a good retentive properties. If I have 4 millimeters of axial wall height, 6 to 8 degrees of taper, and I've got a retentive preparation and my crown isn't going to fall off, I'm not going to worry about bonding that. But if I have a second molar and it's got 2 millimeters of axial wall height, or I have a prep that's, I don't think is real retentive, or maybe the crown has already come off, I'm not going to just keep cementing and hope it stays on. I'm going to bond that crown on. And we're going to show you how we would bond them on. So these are the protocols I was talking about. And this is very important, especially in a total etch technique. This is where rubber dam, to me, is always going to happen. I'm not telling you that you shouldn't do it or you can't do it successfully without it. I just am not going to. I'm always going to use a rubber dam whenever I'm using a total etch technique. So this is glass ceramics with light cure resin. So first thing, we're going to isolate with a rubber dam. We'll disinfect. We'll use Concepts or something on the teeth. I'm a big believer in disinfecting teeth whenever I'm etching teeth. And the reason is a few years ago, I was reading an interesting article and they talked about MMPs, matrix metalloproteinases. And these are basically enzymes that get activated a lot of times when in an acidic environment, i.e. you're etching a tooth. They're basically enzymes that break down collagen, which can affect our bond streaks. So they can be inactivated with disinfectants. So that's why I use disinfectants, and I'm kind of a believer in them because of these MMPs. So we place the phosphoric acid gel on the tooth. If I'm doing 8 teeth, I'll etch 4, rinse, etch 4, rinse. If I'm doing 10, I'll etch 5 and rinse, etch 5 and rinse. I don't want it, especially if it's all enamel, 100% enamel I'm bonded to, I don't care. I'm not worried. It could be on there 10 seconds. 15 seconds. It could be on there 30 seconds. It's not going to hurt. But you don't want to over etch dentin. So if I have some dentin exposed, I really don't want it on there more than about 15 seconds. So I'm going to etch only half the arch and rinse that off in the same order that I etched. We apply our bonding agent. In my case, it's going to be universal adhesive. I'm going to evaporate the solvent lightly by blowing air lightly until nothing moves, and then I'm going to light cure. I failed to mention this earlier, but this is critical. I don't care whose universal adhesive you use. For universal adhesives to work, they go on hydrophilic, which is water loving, which is important when dentin is involved, but they become hydrophobic after they're light cured. So it's critical for the success of universal adhesives before you bond to them or before you see the restoration that you light cure your universal adhesive. And you don't need to worry because they are so thin. The light cure resin cements, the universal adhesives are less than 10, in most cases are less than 10 microns. So they won't interfere with the seat, but it's critical to to light cure after you place your adhesive. Then we place the resin. So this is something I learned years ago. I got really lucky. I took a course that was taught 25 years ago or maybe longer by a dentist named Larry Rosenthal. And he was teaching this course, and I thought I knew a lot about porcelain veneers already, and I found out I didn't know. I was doing them. So because I'm doing it in my office already, I figured, well, I already know so much. What am I going to learn? But I took this course, and I found out I didn't know anything, and I learned a lot. But one of the things, I'd put the cement in the veneer, and I go to put the veneer on the tooth, it'd stick to my finger, and half the cement would come out, and it was a real pain. Well, he showed me a technique where he put the cement on the tooth. And then you can seek the restoration. When it's veneers, now if it's a crown, it doesn't matter. You put the cement in the crown. But when it's a veneer, it's much easier for me to seat a veneer if I put the cement on the tooth and it stays there. Resin cements have enough viscosity to them where they're going to stay where you place them. They're not going to be so runny that they just run off the tooth. So it was a real eye-opening experience. It's just one of the many things I learned, but it really helps me in seating veneers. So I place it on the tooth, which will show you. Then with Light Cure, I want to clean all the cement off. And then I'm going to tack them down at the gingival margin so they don't move when I floss the teeth. I'll show you how we do that. Then we floss the contacts. We Light Cure. After we floss, we Light Cure facial and lingual. Then if there's a little bit of excess and we didn't wipe away, I'll go around with a scaler on the facial, and then I finish the lingual margins with like a football fine diamond. But I don't want to use a diamond or a fluted burr on the facial margin at the gingival margin. I just want to use a scaler right there and then polish them. I don't like to use a burr because the teeth are very delicate right there at the gingival margin. I don't want to use a burr there. And then I'll show you how we do that. Then we use finishing strips to polish the interproximals. We take the rubber dam off, we adjust the occlusion, and then polish. So how do we prepare the restorations? Well, we're going to clean the restorations. Now, glass ceramics, please understand, there's a difference between cleaning glass and cleaning zirconia. Zirconia, you must clean with a cleaner like Ivoclean by Ivoclar or Zirclean by Bisco. Phosphoric acid, you can clean with these products, but you could clean them with anything, acetone, phosphoric acid, or, there are a lot of ways. We just clean them with a phosphoric acid gel and rinse them off, okay? They're going to come etched from the laboratory. If you were to make your veneer in your office or you make your crowns in your office, if you're milling anything chairside, any glass restoration chairside, you know this probably already, but you need to etch those chairside, okay? If it's an Emax lithium silicate, you only etch for like 20 seconds. So anyway, but you can clean with these products if you want, or you can clean glass with just about anything, but you can't clean zirconia with that. You must clean zirconia with a cleaner like Ivoclean or Zirclean, and you must clean zirconia. Because zirconia, well, I'm getting ahead of myself. I'll get to that when we get to zirconia. All right, so we rinse, we dry. For glass, we always use silane. Any glass, feldspathic, lucite, lithium silicate, with silane will give us higher bond strength. So it's etched. So we're going to have the etched surface, which is going to allow us to get bond. And then silane is a coupler, and it has a bipolar molecule that will actually bond to the etched glass, and it will actually bond to the cement. So that's why silane is so important to use, what you'll increase your bond strengths. Now, some companies like Ivoclar incorporate silane and zirconia primer. They have a product called Montbond Plus, and you can use it as your silane and your zirconia primer. Bisco, on the other hand, wants a dedicated silane and a dedicated primer. So they have their silane called Bisilane. They have or ceramic primer. They have two types of primer, two types of silane, and then they have what they call Z Prime Plus for zirconia. So they don't incorporate them together. Some companies do, some don't. Silane, this is important. You don't have to coat it. I mean, you just place a thin layer of silane on the cleaned etched glass. Allow it to sit for a minute, then you dry it with air, then it's ready to go. Set aside by tooth number. Here's our rubber dam. We go ahead, punch 2 holes about an inch down from the top of the frame, and then we cut a line between those 2 holes. I use wingless clamps. I clamp on the first molar, and then I fold this little up underneath the lip, and then this goes around the back, and these go around, the holes go around the back of the clamps. So that isolates the teeth. This folds up underneath the lip, and now I can work hands-free. And I have teeth that are isolated. It's just so simple and easy to use. So here's our case. We've isolated with a rubber dam. So this is something where, because of decay, interproximal restorations, whatever, we've broken contacts. A lot of times I prefer, in this case, I don't like to break contacts, and I won't unless I have to. In the case we're showing here, we have broke contacts, so there is dentin exposed. It's mostly enamel, but there is some dentin, but we're still going to use the total etch technique. This is Conceptus, where we're going ahead, we're doing our rinse, and we're disinfecting. Here we've etched 5 teeth and we rinse. This is Bisco Select HV Etch. It's high viscosity, it stays right where you put it, and it also has benzchloride chloride in it, which is another disinfectant as well. It's another reason why I like it. We leave the teeth slightly moist. Another great thing about universal adhesives, it's not like 5th generation, okay? It's not where moist dent is critical. You can't desiccate the tooth, but you can dry the tooth. It is not as technique sensitive if you dry the teeth. Here we're applying our universal adhesive, multiple coats on the teeth. Here we are lightly drying and evaporating the solvent. Then we light cure, very important step. Here are restorations that have been prepared. And here I am, I'm taking my light cure resin cement and I'm gonna put it right on the teeth. See, everything's isolated. The operatory light's off. I've got plenty of time. I've got until I put a light on these teeth, I've got a lot of working time here. So we've coated all the teeth. Now I can seat the restorations all at one time. I used to do them 2 at a time. And I started teaching with Larry and he said, oh no, we just put them all in. You try them all in, they all fit together. So I learned this technique over 20 years ago and I haven't changed since, because I would put 2 in and I'd get to the back and they wouldn't fit. All of a sudden the contacts were too tight and I couldn't understand why. Or this would start bleeding here before I could get back there. So I put all the cement on, I seat all of them in. Then we take cotton rolls. First off, we make sure everything is seated once all 10 are in. Then we take gauze and cotton rolls, brushes. We wipe away all the excess, everything facial and lingual. There's no excess on these teeth except interproximally. And I can't floss if they're moving around. So I hold my finger on here so it doesn't move. I hold light pressure in a lingual direction here. And then I tack with a very small tacking tip for about 3 to 5 seconds. Go through all 10 teeth. If I can't get floss through, I won't force floss. I'll take one of these little blades and I'll go slightly down and out. And then it allows me to go through and I can floss every contact. I floss and pull through to the lingual. You can see we got a little bit of excess right there, even though we wipe these really good. Sometimes when you're seating, a little bit oozes out. That's why I like to seat by tacking and seating as I'm tacking. Now we're light curing facial and lingual. There's that little excess. I take a scaler and I just take that and I just take that right off. Now we're going ahead. We finish our lingual margins with a football diamond. And we use our polishing strips to polish in approximately. We tap, 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 adjust occlusion, polish with rubber points and cups, and the patient is done. So what about cementing? This is an Emax now. We've talked a lot about this, so I'll go through this kind of quick here. So how do we prepare the teeth? Well, we're going to clean with chlorhexidine. We're going to blot dry, okay? And I'm going to put cotton rolls in because I'm using a self-etch technique here. If I'm bonding for a full crown where there's little or no enamel, and I'm going to put my universal adhesive on, I'm going to lightly air dry, evaporate the solvent. I'm going to inject. While I'm doing that, my assistant is taking the crown. She rinses it, she dries it out, and she takes a dual barrel syringe, whatever cement she's using, and she injects it right into the restoration. I seat on, I have them bite on a cotton roll. You can allow it to gel set, or I do the flash cure, 1 to 2 seconds, clean it off, or the gel set usually occurs in 1 to 2 minutes. I just don't like to wait because I have to keep feeling it to see if it's gel yet. So I do the flash cure, have them bite back on the cotton roll, wait another 2 to 3 minutes. Then I light cure after, first in the gel state, I clean the excess and floss the contacts, then have them bite on the cotton roll, allow the cement to complete self-cure. Then I light cure facial, lingual, and occlusal, adjust occlusion and polish. Lithium disilicate, if you're milled in your office, you etch with 20 seconds. You with hydrofluoric acid, you rinse and dry. Then you are going to clean it after trying with phosphoric acid and after trying or your ceramic primer. Then you apply your silane, wait 1 minute and dry, and place the resin cement in the crown. My assistant does all of that. And then the teeth. So these are lithium disilicate crowns. And you can see they've got the frosty intaglio surface there. So these are 2 lithium disilicate crowns. Today, this is a long time ago. I know they're beautiful restorations, but I'll do these in zirconia now. I don't have to worry about this. The zirconia is stronger and it looks just as good. So here we are with our universal adhesive, because I used to bond all lithium disilicate in. Even if I didn't need to, I just felt better because it was glass bonding it in. So they treated them that way. So here we are, we're filling our crown up. And here it is in the gel state, flash cure in the gel state. And I come in here with my Scalar Explorer, whatever, and I just clean that off, floss the contacts, bite on a cotton roll, wait 2 to 3 minutes, light cure, and then adjust occlusion and polish. That's how we do it. And then we have our adhesive cementation of solid zirconia crowns with a self-etch technique and a dual resin. The same thing. The difference is how you treat the restoration. That's the only difference. You treat the tooth exactly the same way. Our universal adhesive light cure, evaporate the solvent in light cure. However, zirconia, as I said a minute ago, you have to clean it with something like Ivaclean or Zirclean by Bisco, okay? You have to clean zirconia. Zirconia has an affinity for phosphate. That's good. That's why the MDP monomer, which is an acidic phosphate monomer, works so well with zirconia. It has an affinity for phosphate. Zirconia does. So anything that contains any type of phosphate monomer is going to bond well to zirconia. So that's why these new primers like Z Prime Plus, they contain that MDP monomer. So you're going to get higher bond strengths there. So, but your saliva contains phospholipids, and these phosphates in the saliva will adhere to the zirconia, and it'll interfere with bond strength. So you've got to clean that out. And that's why you use the Zirclean or the Ivaclean. So we disinfect or prepare teeth. This is exactly the same thing. Notice the steps are exactly the same. I could have just, it's the same slide we used before. Everything is exactly the same as we did with Emax. Same thing again, exactly the same. All these steps, exactly the same. The difference comes in how we prepare zirconia. We have to clean it with Ivaclean or Zirclean. We rinse, we dry. Now we're going to apply a different, it's not silane, it's a Z Prime Plus, a zirconia ceramic primer, or from Bisco or Ivoclar's Monobond Plus. Remember, Monobond Plus can be used according to the manufacturer for either glass or zirconia because it contains silane in it, okay? We place our dual cure resin cement in the crown, okay? Now, these are zirconia crowns. These are 3Y. These are really strong. These are molars. I would never use 4Y or 5Y. There's no really need to. I might consider if Ivoclar's product is as good as they say, there's a Zircad Prime, then I mean, I guess you get the benefit of 5Y with the 3Y strength. So, but anyway, I'm going to use a strong crown on second molars. And if I got a retentive preps, I don't need to bond these. But if I were going to bond them, this is the way I'd bond a crown. If you have a non-retentive second molar, clean it with Zirclean. This is Ivaclean, or you could use Zirclean. 30 seconds, rinse it out and dry it. Here's our Z Prime Plus. We're applying our ceramic primer. Let that sit for about 30 seconds and dry that. And then she's placing the dual cure, my assistant places dual cure resin cement in the crown. Boom, seat the crowns. Here we are treating the teeth just like before. This is our universal adhesive. I'm telling you, universal adhesives are so easy. Evaporate the solvent like cure. As I'm doing that, my assistant hands me the crowns. They're full, they're ready to go. I put them on there, flash cure, and the excess cleans right off. So easy. Floss the contacts, have them bite on a cotton roll, wait 3 minutes, light cure, just occlusion and polish. The Valsalus Simcore I was telling you about earlier, this is just really quickly a demonstration of that product. They have a dedicated primer, okay? This would be a ceramic primer. It could be used for silane for glass, just like Monobond Plus. It's similar to Monobond Plus. You could use it in glass ceramics or zirconia ceramics. It's the same bottle. That's how you treat your restoration. There's the material. It could be used as a dual cure resin cement. It also could be used as a core buildup material. If you use it as a core buildup material, you treat the tooth with the tooth primer. Same thing if you're bonding on a crown. You put the tooth primer, evaporate the solvent like cure. This would be like a ceramic primer or a silane. This would be like a universal adhesive. Same thing. And they have their own system incorporated with their cement and with their core buildup. Seed it, flash cure. Material cleans off really easy. This is just how nice this gel state is. It's just so easy to clean up. Peel it off, floss the contacts, wait 2 to 3 minutes, light cure, just occlusion and polish. You're all done. Last slide. So I get asked a lot, if I'm going to put in a zirconia, a layered zirconia, or metal ceramics, or lithium silicate, and I have good retention, what cement would you recommend using? I would use in a retentive preparation, I'd be fine with a resin modified glass ionomer. I'd be fine with a self-adhesive resin cement. I'd be fine with the new ion releasing or the bioactive cements. Now, do you need one of every category? Not really, not really. I think any cement on this and any other manufactured cement that falls into any of these categories would work in a retentive preparations for any of those materials. So you really can limit yourself to whatever you like or whatever works good in your hands or whatever you have confidence in. And then lastly, what would I do in a non-retentive prep? I would always bond with a universal adhesive and a dual cure resin cement in a non-retentive situation. And with that, I don't know how I did this, but I have 8:15 Thank you all very much. I will now be happy to entertain your questions. And if I follow Lisa's directions, then here we go. I have some questions. So we're going to spend a little bit of time now trying to thank you all very much that joined us tonight. I really appreciate your attention. And I've got some questions here, and I'm going to try to answer those questions for you. All right, ceramic fractures, whether Emax or zirconia, due to patient cost, what is the best way to bond conventional composites to these materials? Okay, so you can bond to both a glass ceramic or zirconia in the mouth. It's a great question because we just covered what you would do. If it's a glass ceramic, I want to roughen it in the mouth, okay? How would I roughen it? You can use a diamond, or you can use a micro etcher. Danville has some great micro etchers. And so I would use something like a micro etcher to rough that up. If it's zirconia, after roughening it, I'm going to put my ceramic primer on there, Monoline Plus, Z Prime Plus, something like that. I'm going to use a zirconia primer. I'm going to let that sit for a minute. Then I'm going to dry that, and then I'll apply my composite or whatever and bond right to it. If it's a glass ceramic, I'm going to roughen it up again, either with a diamond or some type of micro etcher. I'm going to etch it now. This is different now. With a glass ceramic, you can etch glass. So I'm going to isolate the tooth, and very carefully, when you etch in the mouth with hydrofluoric acid, you have to isolate and be very careful because it can burn gingival tissues. So you don't want, it's very caustic. So your hydrofluoric acid, I would put on the fracture site. I would then let that sit. If it's lithium disilicate, then I would go ahead and leave it for only 20 seconds. If it's a older material like Empress or a feldspathic porcelain, I might leave it on there for a little bit longer, say like a minute after micro etching. I rinse that off and dry it. You should see kind of a frosty appearance. That means you've got it etched. Then I dry that really good. I put silane. I let the silane sit for a minute, and then I go ahead and paint my, then I would come in with an adhesive. I would use either some type of an unfilled resin, say like the bonding resin of a 4th generation, or you could even use a universal adhesive, evaporate the solvent or thin it out, and then light cure that, and then place my composite over that. I used to think that I paint an adhesive over the Z Prime, but I was talking to people at Bisco, and he said no. He said you don't need to come back with an adhesive over the Z Prime. They said you can bond right to the primed zirconia. So if I'm repairing zirconia, that's the way I would do it. If I'm repairing glass, that's the way I would do it with glass. So it's different. Remember, same thing with bonding it in the mouth. Glass ceramics can be silanated. Okay, they could be etched and silanated, which is going to give you really good bond strengths. It's one of the reasons why if somebody asks me, well, why would you use, I don't have a problem with the 5Y translucent zirconia. It's beautiful. But if I'm going to do it anteriorly, it's going to be a full crown. If it's a veneer, I want my veneer to be a glass ceramic because I just feel like I can really bond, and I know you can get relatively high bond strengths. Bisco's done some studies with their Z Prime Plus where they're talking about 26 to 30 megapascals of strength, bonding to zirconia. So I mean, I know you can get bond strengths, but I still like the comfort level, I think, of doing it with having silane, having hydrofluoric etching my glass and using silane. All right, so my next question is regarding your older patient, likely beveled enamel, supragingival margin, and bioactive high noble gold alloy in the presence of oral balance wellness. Okay, I'm not really sure I'm following this, but in older patients, I really, I'm going to go with, aesthetics is not going to be, and longevity is not going to be a thing. I'm going to go with probably something that's that's going to release ions if I can, okay, because they're going to have decreased salivary output, so that's going to affect them. They're going to be more likely to have acid erosion or something like that. So maybe a material that releases fluoride, any type of restorative material. I think glass ionomers would be good for them. If you're talking about, I don't really do much gold alloys anymore. It's a great restorative material, but it's expensive, especially high noble gold, which is in the question. But I'm going to look for, sure, if I could use bioactive materials, especially on elderly patients, I'm looking for that. And I'm looking for something. And again, I want to etch teeth there because, their teeth are, you know, their teeth are going to maybe be a little bit harder to etch or bond to. Bond shrinks are going to be decreased a little bit. So if I'm doing a restoration, I'd still probably look at zirconia. I can, bond zirconia if I need to, or cement it with a bioactive cement. So that's kind of what I do for an older patient. What kind of disinfectants do you use on prepared teeth? There are a lot of good ones out there. I started using Conceptus many years ago because I read an article and they said that you could actually increase bond strengths by using Conceptus and then using oh God, I can't even think of the product now. Oh gosh. Anyway, to cause decrease sensitivity in teeth. Anyway, I can't think of it. I'm sorry, I apologize. My mind's going a little bit. But anyway, there were a couple of things you could put on the teeth, but one of the things was disinfecting the teeth prior. You could actually increase bond strength. So I like to do that, and I use a Conceptus because Ultradent has these great little syringes with the little tips on them that just make it real easy to apply. But Bisco, I know, has a great antimicrobial. A lot of companies have a lot of really good ones. So yes, do I use disinfectants? Yes, we do. Please comment on Clearfill APX. I've heard that it's a biomimetic material and the hardness similar to that of dent and enamel's interface, so that it can be used in build-up material. And as a cement, yeah, I think it's going to be a lot like Simcor. The same thing I was just telling you about, kind of like two products in one. It can be used as a cement or a build-up material. Clearfill, Cure has some great products. They were the innovator. They led the way for self etching primers and the self etch techniques that we saw. So yeah, I would imagine APX is a good product, just like I like Kettenbaugh's Simcor for the same reason. You kind of get two products in one there, and it does. If it's like Simcor, which I have used, I evaluated it for Catapult and really liked the product, and I would use it. Again, I evaluated and liked it, but when I prep it, it does prep like dent. It has a really bright white color, so it's easy to distinguish from the tooth as well. And I'm sure this product, I'm not familiar with it, but if it's anything like other Clearfill products, I'm sure it's a good product. And if it probably does exactly what you said in the question there. Can I use a glass ionomer Fuji 1 on a conventional cementation of zirconia crown? Yes, you can, but you'd be better off, I think, using a resin-modified glass ionomer. I would use Fuji Sim Evolve or Fuji Sim 2. I think you're going to get the same benefits you get from the glass ionomer Fuji 1, but you get increased physical properties, and you can also have that especially with Evolve, with the new Evolve, you can do that flash cure with the gel state cleanup that makes it really easy and fast to clean up. So yeah, can you use it? Yeah, that's just like I was trying to say with cements, you can use zinc phosphate and polycarboxylate, and you can get results with those, but there's just materials that I think are better. There's nothing wrong with your glass ionomer Fuji 1, nothing whatsoever. But I just think there are some other things that are going to be a little bit better for you, and I think you might like better, especially the Fuji Sim 2 and the Fuji Sim Evolve. I think you'd like those. Oh, thank you. Somebody said, spoken clearly and at a good pace. Sometimes I've told I speak too fast. So anyway, it was an anonymous attendee, but if you're still on, thank you for that. I appreciate you saying that because it is getting a little late at night and I did work today. So I didn't know and we finished kind of like on time. So I was kind of excited about that too. But anyway, sometimes I'm told they don't believe I'm from Alabama because they say I've talked too fast to be from Alabama, but I don't know why I talk fast. I think I always have. I think it has something to do with I tend to be an impatient person. And so maybe if people are talking real slow, I have a friend that has a real Southern drawl, and when he's talking, I want to finish the sentences for him. So anyway, thank you for that. All right, we have can I use a glass ionomer? Oh, I guess that's a repeat question there. So that was the one about Fuji 1. That was the same question. Is Cure's Photobond passe or still a good dual cure primer and bond? Okay, so, that's a great question. And I guess we're getting a lot of Cure questions tonight. So I don't know. We got a lot of Cure, and good. It's a great company, and then they have great products. Yes, a dual cure primer is fine. especially with dual cure resin cements and self-adhesive resin cements. It's good to use that. So if the manufacturer, I would still use a universal adhesive, but if the manufacturer says in their instructions, if you're going to use this adhesive with a dual cure cement or a self-cure cement, you need to use a dual cure primer, then I would use it. Okay. If they're saying it's not necessary, like Visco says with Allbond Universal, it's not necessary to use a dual cure primer, then I wouldn't worry about it. So, it depends. So I'm fine, with either way, as long as you read the manufacturer's instructions and do what the manufacturer tells you to do. So that's actually my last question. So, Lisa, I guess we didn't run over. That's, at least if I'm not mistaken, if those aren't the questions, I mean, that's all I see on here. I'm scrolling down and I don't see any more questions on here.
No,
So
you're correct. That was actually
Okay.
the last one.
Okay. So I guess that wraps us up for tonight then. I want to just take this opportunity to thank everybody that attended tonight. Lisa, thank you for your hard work. I really love working with you. I appreciate everybody's their attendance, and hopefully this was helpful for you. And I appreciate you being here tonight. Thank you all so much.